Hello everybody. Today we are going to discuss about the newer antibiotic which are used in treatment of the gram-negative organism. So if it is culture confirmed multi-drug resistance organism, then it is divided into carbapenem resistant enterobacterial, that is CRE, then carbapenem resistant Pseudomonas aeruginosa, and MDR Acinetobacter baumannii. If it is CRE, then it is divided into, if there is a presence of carbapenemase, then it is divided into MBL, OXA48 and KPC. In case of MBL, the treatment line is ceftazidime avibactam plus aztreonam or or cefiderocol. If it is OXA48, then the treatment line is ceftazidime avibactam or we can use cefiderocol. If it is KPC, then we can use ceftazidime avibactam, imipenem, relibactam, cefiderocol or meropenem, veibarbactam. If there is resistant to avibactam or relibactam or veibarbactam, then we can use cefiderocol, polymyxin-based antibiotic, high-dose carbapenem, or aminoglycoside-based antibiotic or and high-dose carbapenem. Plus, we can add tigecycline, iracycline, or we can add phosphomycin. Then, in the absence of new option, we can use the combination therapy with colistin, polymyxin, aminoglycoside, phosphomycin, tigecycline. If it is difficult to treat Pseudomonas aeruginosa, then we can use ceftolazone tazobactam or ceftazidime avibactam, cefiderocol plus older agent, that is colistin, polymyxin, aminoglycoside, phosphomycin, and plazomicin. If there is resistance to avibactam or relibactam or veibarbactam or ceftazidime tazobactam, then we can use polymyxin or aminoglycoside based antibiotic plus carbapenems or phosphomycin and rifampicin. If it is MDR Acinetobacter baumannii, then we can use cefiderocol or polymyxin based antibiotic plus rifampicin, phosphomycin, tigecycline, carbapenem, and older aminoglycoside. So, according to IDSA, so we can divide this MDR organism into ESBLE, Pseudomonas with difficult to treat resistance. If organism is ESBLE and the focus is cystitis, then the preferred treatment is nitrofurantoin, trimethoprim, sulfamethoxazole, and the alternative treatment is amoxicillin clavunet, single dose aminoglycoside, and phosphomycin. If it is pyelonephritis and complicated UTI, then the preferred treatment is artepinim, meropenem, imipenem, cilastatin, ciprofloxacin, levofloxacin, or trimethoprim, sulfamethoxazole. If there is infection outside the urinary tract, then the treatment line is meropenem, imipenem, cilastatin, artepinim. Oral step-down therapy to ciprofloxacin, levofloxacin, trimethoprim, sulfamethoxazole can be considered. If the organism is Pseudomonas aeruginosa with difficult to treat resistance, and if the focus of infection is cystitis, then the treatment line is ceftolazone tazobactam, ceftazidime avibactam, imipenem relibactam, and cefiderocol or single dose of aminoglycoside. Alternative agent is colistin. If it is pyelonephritis and complicated UTI, then also we can use ceftolazone tazobactam, ceftazidime avibactam, and this imipenem, cilastatin, relibactam, and cefiderocol. If it is infection outside UTI, we can use ceftolazone tazobactam, ceftazidime avibactam, imipenem, cilastatin, relibactam. The alternative treatment is cefiderocol or aminoglycoside monotherapy limited to uncomplicated bloodstream infection with complete source control. For complicated pyelonephritis also, we can alternative therapy is aminoglycoside. So if it is carbapenem resistance enterobacter, then and if the focus of infection is CRE, the preferred treatment is ciprofloxacin, levofloxacin, trimethoprim, sulfamethoxazole, nitrofurantoin, single dose of aminoglycoside, or we can use meropenem only if ertapenem resistance or meropenem susceptible, and carbapenem testing results are either not available or negative. Alternative treatment is ceftazidime avibactam, meropenem veibarbactam, imipenem cilastatin relibactam, and cefiderocol. Colistin only when no alternative options are available. If it is pyelonephritis and complicated UTI, the preferred treatment is ceftazidime, avibactam, meropenem, vaborbactam, imipenem, cilastin, relibactam, and cefiderocol. Meropenem in form of extended infusion only if ertapenem is resistant, meropenem susceptible, and carbapenem's testing results are either not available or negative. Alternative treatment is once only aminogliptin. If it is infection outside the urinary tract infection and if resistant to ertapenem but susceptible to meropenem or carbapenem's testing results are either not available or negative, then we can use meropenem in the extended infusion, or we can also use ceftazidime avibactam. If it is infection outside the urinary tract and if it is resistant to ertapenem, meropenem, and carbapenem's results are either not available or negative, we can use ceftazidime avibactam, meropenem vaborbactam, or imipenem cilastin relibactam. The alternative treatment is cefiderocol, tigecycline, and ivarsite. If KPC is identified, then the treatment line is ceftazidime avibactam, meropenem vaborbactam, imipenem cilastin relibactam. The alternative treatment is cefiderocol, tigecycline, irvacycline in case of intra-abdominal infection. If it is MBL, that is NDM, VIM, or IM, and carbapenemase is identified, then the preferred treatment is ceftazidime avibactam plus aztreonam and cefiderocol. Alternative treatment is tigecycline, irvacycline if intraabdominal infection is identified. If there is OXA48 like carbapenemase infection, then we can use ceftazidime avibactam. Alternative treatment is cefiderocol, tigecycline, and irvacycline in case of intraabdominal infection. Main therapies currently used for MDR gram-negative bacterial infection. Older treatment. Older antimicrobial are still commonly used for treating gram-negative infection, usually as a combination, especially when certain type of MBL producing organisms are common, and for carbapenem resistant Pseudomonas aeruginosa, Acinetobacter baumannii, although their use in infection caused by KPC producing CRE is more questionable. These agents include colistin, phosphomycin, tigecycline, aminoglycoside, peracillin, tazobactam, and high dose carbapenem. Now about colistin, the optimum use of the colistin in MDR gram-negative infection is subject to debate. Despite its association with nephrotoxicity and neurotoxicity, there has been resurgence in its use because of the increased prevalence of carbapenem-resistant species. In MDR gram-negative nosocomial pneumonia, colistin is used in an effort to address high morbidity and mortality rate in patients hospitalized for the pneumonia. In an Italian cross-sectional study assessing colistin use in high-risk adult, colistin was given most often in combination with agent for MDR gram-negative organism, mainly for targeted therapy of lower respiratory tract infection and bloodstream infection caused by carbapenem-resistant organisms. Furthermore, resistance to colistin is now emerging, and as evidenced by highly virulent strain of E. coli found to be resistant to colistin via MCR1G. Then the next agent is phosphomycin. Phosphomycin was discovered in 1960s and has been used for many years, particularly in the treatment of UTI. It has unique mechanism of action which inhibited the UDP GLC NAC enor transferase, which is the first step in the synthesis of bacterial cell wall, rendering it useful in the treatment of resistant gram-negative or infection. Indeed, resistance is driver of many recent increase in its use. Resistant to phosphomycin itself is most commonly via amino acid replacement or peptidoglycan recycling in the formation of bacterial wall, and cross resistance is uncommon. Phosphomycin is particularly active against E. coli as well as some carbapenem resistant bacteria. Phosphomycin with piperacillin tazobactam in patient with complicated UTI caused mostly by E. coli, and phosphomycin was non-inferior in the primary outcome of clinical cure and the microbial eradication. E. coli eradication was 100% with fosfomycin. Hypokalemia was more common with the fosfomycin group. And in fact, intravenous fosfomycin is known to be associated with sodium overload and hypokalemia. Therefore, administration of potassium supplement is recommended. Furthermore, because fosfomycin is eliminated mostly by the kidney, it should be administered with caution in patients with renal impairment and dose adjustment may be necessary. Tigecycline, while active in vitro against carbapenem-resistant Enterobacter and carbapenem-resistant Acinetobacter baumannii, tigecycline is generally used in combination with other agents. It is recommended for use in MDR skin and soft tissue infection and abdominal infection and in combination with other agents for hospital-acquired respiratory infection, although not for VAC. There is evidence of Acinetobacter baumannii resistance to tigecycline via overexpression of ADABC efflux pump and or breakthrough infection. Furthermore, tigecycline may not achieve the tissue level necessary to treat pneumonia, meaning high dose therapy is often needed. Therefore, high dose tigecycline based combination should be reserved for critically ill patients with carbapenem resistance enterobacterial infection and limited treatment options. About aminoglycoside have been used for many decades to treat gram-negative nosocomial pneumonia and more recently have been used to treat infection caused by carbapenem-resistant gram-negative bacteria. Traditionally used in combination, aminoglycosides such as amikacin, gentamicin, and tobramycin are used as monotherapy in UTI only, where they demonstrate considerable effectiveness. In carbapenem-resistant enterobacterial associated condition other than UTI, they are associated with unacceptably high mortality when given alone. They are used in cases of polymyxin resistance, but aminoglycosides are susceptible to several resistant mechanisms, including reduced uptake, target modification through mutation, and enzymatic inactivation. Furthermore, when given in combination with food beta-lactamase, IV aminoglycoside increase the risk of nephrotoxicity compared with beta-lactam alone in patients with VAC. Inhaled amikacin initially showed promise, but the recent IASIS and inhaled study have shown no clinical benefit in adding inhaled amikacin to IV standard care of VAC. Of note, aminoglycosides are known to cause nephrotoxicity. In addition, they have decreased the activity at lower pH of airway, lining, and concentration of aminoglycoside detected in the lung tissue may not be sufficient to effectively treat VAC. About piperacillin tazobactam, BLBLI piperacillin tazobactam is broad-spectrum antibiotic with activity against multiple gram-negative pathogens and is one of the few agents that is active against Pseudomonas aeruginosa. In patients with E. coli and Klebsiella pneumoniae, bloodstream infection, and ceftriaxone resistance, piperacillin tazobactam showed no benefit over meropenem in terms of 30-day mortality. In many critically ill patients, as well as patients with mild to moderate renal impairment, typical dose of piperacillin tazobactam, that is 4.5 gram, 3 times daily, is insufficient to achieve effective bactericidal concentration, and dose adjustment may be required. About newer treatment, ceftazidime avibactam. Ceftazidime avibactam is the novel combination of third generation cephalosporin, ceftazidime, and BLI, that is avibactam, with indication including hospital acquired pneumonia and ventilator associated pneumonia. Ceftazidime avibactam was approved in USA in 2015 for treatment of complicated intra-abdominal infection in combination with metronidazole and complicated UTI including pyelonephritis in patients aged 18 years. Ceftazidime avibactam given as monotherapy or in combination with other agent was superior to other treatment regimen including carbapenem plus aminoglycoside, colistin, and other regimen against carbapenem resistance Klebsiella pneumoniae bacteria. In patients with KPC producing Klebsiella pneumoniae infection, ceftazidime avibactam proved to be reasonable alternative treatment option to colistin and was associated with lower risk of nephrotoxicity. Given ceftazidim's inhibitory profile against OXA48-like enzyme and its stability in presence of hydrolyzing enzyme, ceftazidime avibactam is preferred agent for the treatment of infection caused by OXA48 producing carbapenem-resistant enterobacter. The REPROVE study confirmed that ceftazidime avibactam is non-inferior to meropenem in HAP and including VAP. Now, the next drug is meropenem vaborbactam. Meropenem vaborbactam has been approved in the USA for the treatment of patients aged 18 to 64 with complicated UTI, including pyelonephritis. In Europe, since 2017, in Europe, meropenem vaborbactam was approved in 2018 for treatment of adult with complicated UTI, including pyelonephritis, complicated intraabdominal infection, hospital-acquired infection, including VAP. Meropenem vaborbactam is also indicated for the treatment of patients with bacteremia that occurs in association with or suspected to be associated with any of above infection and for treatment of infection due to bacterial organism in adult with limited treatment option. The combination of well-known broad-spectrum carbapenem, meropenem with vaporbactam, a first-in-class boronic acid inhibitor of class A and class C beta-lactamase, had excellent in vitro activity against KPC-producing enterobacterial isolate from around the world collected in 2014 and 2015. Meropenem vaborbactam demonstrated marked activity against enterobacterial strain producing KPC carbapenemase with less but still notable activity against those that produced MBL and OXA48-like enzyme. It is administered as a high-dose prolonged infusion, that is 2 grams of meropenem, 2 grams of vaporbactam over 3 hours every 8 hours to optimize pharmacokinetic and pharmacodynamic exposure, resulting in enhanced bacterial killing. Pseudomonas aeruginosa is considered clinically relevant pathogen for meropenem vaporbactam in Europe but not in US. Meropenem vaborbactam was approved in USA in 2017 for treatment of complicated UTI and acute pyelonephritis based on the result of Tango 1 study, which showed non-inferiority of meropenem vaborbactam to piperacillin tazobactam. Early real-world experience with the meropenem vaborbactam further supports effectiveness of meropenem vaborbactam demonstrated in clinical study, showing that the combination was able to achieve clinical success in 70% of severely ill patients with gram-negative CRE infection, including nosocomial pneumonia, complicated UTI, intra-abdominal and soft tissue infection. Now about ceftolozane tazobactam. It is another BL-BLI combination. It was approved in the USA in 2014 for the treatment of complicated intra-abdominal infection in combination with metronidazole and complicated UTI, including pyelonephritis. In Europe, ceftolozane tazobactam was approved in 2015 for the treatment of complicated intra-abdominal infection, acute pyelonephritis, complicated UTI, and hospital-acquired pneumonia, including VAP. Unlike some other cephalosporin, it is active against AMC beta-lactamase, especially Pseudomonas aeruginosa. In the ASPECT NP study, ceftolozane tazobactam was non-inferior to meropenem for treating gram-negative nosocomial bacteria. Cure rate of ceftolozane tazobactam have been found to be lower in patients with renal impairment, so dose adjustment may be required in patients with impaired renal function. UK clinical practice guideline recommended ceftolozane tazobactam for treatment of complicated UTI caused by resistance gram-negative infection. It may be useful treatment option for severe infection caused by carbapenem-resistant Pseudomonas aeruginosa, provide susceptibility is confirmed. Now the next agent is imipenem relibactam. Relibactam is novel class 4 A and C beta lactamase inhibitor, which when combined with imipenem restores the latter's activity against KPC producing CRE, Klebsiella pneumoniae, and Pseudomonas aeruginosa, but not Acinetobacter baumannii. Similarly, imipenem relebactam had shown in vitro activity against KPC producing enterobacterals and MDR Pseudomonas aeruginosa, but not active against Acinetobacter baumannii clinical isolates. In 2019, imipenem relebactam was approved in USA for treatment of complicated UTI, including pyelonephritis and complicated intra-abdominal infection in patients aged 18 years with limited or no alternative treatment option. Imipenem relebactam has been investigated in the treatment of imipenem-resistant hospital-acquired infection, ventilator-associated pneumonia, complicated intra-abdominal infection, and complicated UTI. Restore IMI conducted in patient with HAP, VAP, and complicated intra-abdominal infection, complicated UTI caused by imipenem-resistant enterobacterals reported favorable response in 71% of patients receiving imipenem and relevant. Now, the next agent is cefoperazone sulbactam. Cefoperazone sulbactam was found to have in vitro activity against 91.6% of enterobacterals according to recent data published on behalf of the Sentry Antimicrobial Surveillance Program, meaning it is one of the most active compound in the vitro. In study comparing cefoperazone sulbactam with tigecycline for bloodstream infection due to carbapenem-resistant Acinetobacter, 28-day mortality was significantly higher with tigecycline. In patients with bloodstream infection due to ASBL producing Enterobacter, there were no statistically significant difference between patients treated with cefoperazone sulbactam and those treated with carbapenem in terms of success rate, sepsis-related mortality, and 14-day mortality. In HAP and the healthcare associated pneumonia, cefoperazone sulbactam demonstrated non-inferiority to cefepime. Then the next agent is iravacycline. Iravacycline is the tetracycline antibiotic that is effective in vitro against many microorganisms that are resistant to other tetracycline, including MDR Acinetobacter and ESBL producing enterobacterial species. Two randomized double-blind studies, that is IGNITE, demonstrated in terms of clinical cure rate, iravacycline was non-inferior to ertapenem and to meropenem in patients with complicated intra-abdominal infection. Iravacycline is generally well tolerated and most common adverse events are nausea, vomiting, and infusion site reaction. Iravacycline is expected to provide valuable therapeutic option for patients who cannot tolerate beta-lactam or fluoroquinolone and may help reduce the use of quinolone, carbapenem, and beta-lactamase inhibitor. Then the next agent is plazomicin. The novel semisynthetic aminoglycoside plazomicin is the active against enterobacterial but is less active against non-fermenting gram-negative bacteria due to its vulnerability to ribosomal ribonucleic acid methyl transferase. Plazomicin is currently approved by US Food and the Drug Administration for the treatment of complicated UTI. However, the application of marketing authorization for plazomicin in Europe was withdrawn in 2020. Plazomicin was evaluated in patients with serious carbapenem resistance enterobacterial infection in CARE study, which although it was terminated early because of low study enrollment, found that plazomicin was associated with reduced all-cause mortality at 28 days compared to colistin. So plazomicin was found to be more active in vitro than traditional aminoglycoside. These results taken together with the encouraging results from CARE study suggest that plazomicin may have an important role in the management of carbapenem resistance enterobacterial infection, particularly complicated UTI. Then the next agent is cefiderocol. The novel Cidro4 cephalosporin, cefiderocol, is active in vitro against variety of ambler class A, C, D beta lactamase, and it is the first agent with activity versus class B beta lactamase. This confers activity against MDR gram-negative bacilli including MDR enterobacterel, Pseudomonas aeruginosa, Acinetobacter baumannii, Stenotrophoma maltophilia, while possessing safety and tolerability profile similar to other cephalosporin. Cefiderocol was assessed in phase 3 study, Credible CR, to compare its effectiveness with best available therapy in patients with CRE gram-negative pneumonia, complicated UTI, or bloodstream infection sepsis. Cefiderocol was approved in USA in 2019 and in Europe in 2020 for treatment of infection, including pyelonephritis caused by gram-negative microorganism in patients aged 18 years. However, the indication is limited to patients with limited or no alternative treatment option. Thank you, guys.